Good afternoon to all of you. Welcome you all to clinical combined round. And for today, we are on hematology to present a case. A little bit unusual. We have seen patients who are still rare, but major concern is bleeding manifestations. To present, I would like to invite Dr. Karthikeya followed by Tarun. Thank you.
Very good afternoon. We'll be presenting the CCR titled Anemia, Bleeding and Immunity. We have a 65-year-old male who presented to us with the complaints of known case of hypertension and diabetes, and presented to us with the chief complaints of shortness of breath from the last 4 months and bleeding manifestations in the form of skin bleeds, GI bleeds, and bleed from the venipuncture sites for the last 3 months. The patient complained of generalized weakness, easy fatigability, shortness of breath, and exertion from the last 4 months, which was insidious in onset and gradually progressive in nature and progressed from NYHA class 1 to NYHA class 3. Also, from the last 3 months, the patient had various symptoms, including spontaneous, non-traumatic swellings over back, bilateral thigh, right lower limb with pain and which was associated with pain and blackish bluish discoloration of skin, with maximum dimensions of 5 into 4 centimeters over back, and in a course of time developed over bilateral thigh as well as the right arm. These were atraumatic, non-progressive, non-edematous, and non-itchy, and persisted for around 15 to 20 days after onset and resolved gradually with time. There was also history of prolonged bleed from venipuncture sites after routine sampling, history of intermittently black-colored stools. There was history of around 6 units blood transfusion over the last 4 months and FFP during an episode of long bleeding after venipuncture sampling. In negative history, there was no history of orthopnea, cough, chest pain, palpitations, middle edema, no history of fever, wheezing, snoring at night, excessive daytime sleepiness, no history of difficulty in swallowing, change in voice, weakness in any limb, no history of yellowish discoloration of sclera, ascites, history of erythematitis, or any autoimmune stigmata. Also, there was no history of any anticoagulant or antiplatelet intake, and no history of any weight loss or loss of appetite. Past history, the patient is a known case of type 2 diabetes mellitus and hypertensive on OHAs and antihypertensives and is controlled on medication. Rest of the past and personal history were non-significant. Also, the general physical examination, the vitals were normal, and on GP, only significant finding was pallor. There is also on this local examination, there was a large ecchymotic patch over the medial aspect of right arm measuring 18 into 8 centimeters, which was non-blanching, non-palpable, with no punctum, no oozing of blood, surrounding skin was normal, and the lesion was non-tender. The rest of the systemic examination were normal. Summarizing our case, we have a 65-year-old male, known case of type 2 diabetes mellitus and hypertension, who is controlled on OHAs and antihypertensive, presenting to us with new onset bleeding manifestations in the form of skin, both ecchymosis and hematomas, and GI bleeding. There is also complaints of anemia-related symptoms with transfusion requirement. Most likely, the anemia is secondary to the bleeding manifestations. There is no major organ involvement as per history and examination. Coming to the differentials of a new onset bleeding manifestation in an elderly patient, the disorder can be of primary hemostasis or secondary hemostasis. Primary hemostasis is defects in the platelet plug formation leading to immediate mucosal or skin bleeding, and these can be the common differentials in an elderly population, including thrombocytopenia, platelet dysfunction secondary to drugs or uremia, von Willebrand disease, or vascular disorders. Other differential can be secondary defects in secondary hemostasis, which is due to the defects of coagulation cascade related resulting in delayed bleeding into muscles or joints, and can be secondary to liver diseases, vitamin K deficiency, DIC, acquired hemophilia, anticoagulant therapy, also rarely neoplasm, systemic diseases, as well as GI tract disorders. Reviewing the investigations that the patient had underwent outside, on CBC, the patient had an anemia of 4.5 grams per deciliter. The patient received blood transfusion on this report. However, the platelet count was normal, KFT, LFT were normal, On the screening coagulogram, the PT was normal, however, APTT was markedly prolonged, and the patient did not clot on the APTT examination. The stool occult blood test was positive. The upper G endoscopy and colonoscopy were normal, and a CT scan done outside for chest and abdomen were also normal. Now, based on this test, we can think the disorders of primary hemostasis looks little less likely, and disorders of secondary hemostasis look more likely because the APTT is markedly prolonged, and most likely this is a disorder of coagulation. Liver diseases is less likely because the liver function tests were normal. Vitamin K deficiency also less likely because the PT was normal. DIC, the platelet count were normal, the PT was normal. There is no history of any anticoagulant therapy, so that is also unlikely. There is no evidence of neoplasm in the form. The patient did not have any weight loss, no loss of appetite. The imaging were also normal. And there is no evidence of any other systemic diseases. What we have is acquired disorders of coagulation, including acquired hemophilia or acquired von Willebrand disease. Now, handing over to Dr. Karuna for the investigations done at our institute.
So we'll start with coagulation workup. So if you see in this, only APTT is prolonged, and whenever APTT is prolonged, we do something called a mixing study, where we mix half the patient's plasma with normal pool plasma, which will be a source of coagulation factors. And if the APTT gets normalized after this, it suggests a factor deficiency, whereas if it doesn't correct after this, it suggests a factor inhibitor, which inhibits the clotting factors even in the pooled normal plasma. So for this, we use something called Rossman's index for this calculation, and if it is more than 15%, it suggests no correction, suggesting inhibitor. And in our case, mixing, like you can see the basically the patient's value, and the mixing value is almost same, suggesting there is no correction, and Rossman's index is more than 15%. So based on this, we have a prolonged APTT which is not getting corrected on mixing, and this suggests inhibitor. And inhibitors can be either immediate acting or they can be time and temperature dependent, which is usually assessed after 2 hours. For immediate acting inhibitors, we have lupus anticoagulant, factor 9, factor 11, or von Willebrand factor inhibitors, or even sometimes high titer factor 8 inhibitors. And for time and temperature dependent inhibitors, we have factor 8 inhibitor. So to summarize till now, we have prolonged APTT, and it does not get corrected on mixing, suggesting an inhibitor. And since lupus anticoagulant is something which we see very commonly, and our inhibitor was also immediately acting, we did screening for lupus anticoagulant by a test called DRPT, and this was negative. So next steps, we did factor 8, factor 9, and von Willebrand factor levels. So at this time point, both factor 8 and factor 9 values came out to be less than 1%. So now at this time point, so can it be an inhibitor against both factor 8 and factor 9? So coming to inhibitor titers, we do some like an assay called Bethesda assay. So in that, factor 8 titer turned out to be 1882 BU per ml, which is very high, and factor 9 titer was negligible. So the reason for this, even though factor 9 titer is negligible, the factor 9 level was less than 1%. And the reason for this is the factor 8 inhibitor titer is very high, that it inhibits the factor 8 in the factor 9 deficient plasma used in our one-stage automated assay for factor 9 level. So our final diagnosis was made as acquired hemophilia A. So I call upon Dr. Karthikeyan for discussion.
About acquired hemophilia A, it is a rare bleeding disorder with an incidence of around 1.5 cases per million persons per year, and it is due to circulating autoantibodies directed against a specific clotting factor, in our case factor 8. And also the factor 8 inhibitors are the most commonly reported autoantibodies. The median age of patients is 73 years, and the majority of the patients are greater than 65 years. There are two, the age distribution is biphasic, one small peak between 20 to 30 years, which is mainly comprised by postpartum females, and the rest of the major chunk characterized by elderly population. The incidence is equal among males and females. Around 50% of patients do not have an underlying disorder. However, 50% patients have underlying etiology, including cancers, which can be both hematological as well as solid, including lung, prostate, pancreas, autoimmune conditions such as SLE, rheumatoid arthritis, pregnancy, as I told, especially among the 20 to 30 age group patients, drug-induced, including cephalosporin, sulfa drugs, methyl dopa, fludarabine, dermatological causes including psoriasis and pemphigus, and other disorders such as hepatitis B, C, and HIV. The antibodies that are seen in acquired hemophilia follow a type 2 inactivation pattern, which means that there is variable levels of residual factor VIII activity despite presence of high titers of factor VIII inhibitors, which means that the patient might have residual factor VIII activity despite having a large amount of inhibitors, which is opposite to that what is seen in congenital hemophilia with inhibitors, because in congenital hemophilia inhibitors, there is complete inactivations in a linear relationship between antibody titer and residual factor VIII activity. Coming to the clinical manifestations, the patients most commonly present with subcutaneous bleeding in around 80% of patients, followed by muscles, gastrointestinal, genitourinary, and retroperitoneal bleeds. Joint bleeds, which is the most common bleeding manifestations in patients with congenital hemophilia. Joint bleeds are rarely seen in acquired hemophilia. And also, patients may not always bleed at presentation and might only have raised APDT as the only sign of acquired hemophilia. Also, it is seen that in patients of acquired hemophilia have more severe bleeding phenotype in comparison to the patients of congenital hemophilia with inhibitors. This is a chart highlighting that there is significant delay between the bleeding manifestations and the diagnosis of acquired hemophilia, with around 60% of patients being diagnosed with acquired hemophilia A after 1 week of diagnosis, 1 week of bleeding manifestations. Coming to the management of acquired hemophilia A is two-pronged, with primary aim being management of acute bleeding, controlling the acute bleeding episodes, and second, the eradication of autoantibodies by immunosuppressive therapy. The response criteria used for response is partial response is defined as factor VIII activity greater than 50 international units per deciliter, and no active bleeding after stopping the hemostatic drugs, and complete remission defined by partial remission plus absence of any inhibitors, also steroids being tapered less than 15 mg per day. Management of acute bleed. Acute bleeds are managed with the use of bypassing agents. These are the various bypassing agents which can be used. This is recombinant factor 7A, which can be given at dose of 90 microgram per kg every 2 to 3 RD, or activated prothrombin complex concentrate given at the dose of 50 to 100 units per kg every 8 to 12 RD, or if available, recombinant porcine factor 8 at the dose of 200 units per kg, followed by, depending on the patient's bleeding phenotype. Also, prior to giving the porcine factor 8, we need to check for presence of antibodies against the porcine factor 8 before administrating it. Unicizumab is a monoclonal antibody which acts as a bypassing agent of factor 8, and it is very rampantly used in patients with congenital hemophilia, both with or without inhibitors, and it has been shown in some studies to be effective in patients with acquired hemophilia A as well, with reduction in the usage of hemostatic treatment, also the reduction in the bleeding phenotypes. Coming to the immunosuppressive therapy, what immunosuppressive therapy is to be given to the patient is defined by what is the factor VIII level, whether it is greater than 1% or it is less than 1%. If it is greater than 1%, the patient can be given a single agent steroid alone for 3 to 4 weeks, and if the patient does not achieve even a PR after 3 to 4 weeks, we need to add another cytotoxic agents or rituximab. However, if the patient factor VIII baseline levels is less than 1% and the inhibitor titer is greater than 20 Bethesda units, we need to start the patient on dual agent steroid with either cytotoxic agents or rituximab for 3 to 4 weeks. And if the patient does not respond, we need to add a third line agent as well. These are all the second line therapies which are recommended, including MMF, cyclosporin, tacrolimus, cyclophosphamide, as well as cortisone. These are the data from the largest three registries of acquired hemophilia, and as we can see, the acquired hemophilia is associated with high mortality risk up to the tune of 40% in our patients, despite having very good initial responses up to 70 to 80%. Coming back to our patient was started on steroids at a dose of 1 mg per kg and cyclophosphamide at 2 mg per kg. And after 1 month of therapy, there were no subsequent bleeds. However, the factor VIII levels after 1 month of therapy was still less than 1%, and factor VIII inhibitor titer was also 225. Uh, Sadly, our patient developed febrile neutropenia secondary to cyclophosphamide that we were giving him, and developed UTI sepsis and succumbed to the same illness. This is our published data on acquired hemophilia, and we can see in this study population there were 3 patients and with postpartum acquired hemophilia. Rest of the patients were elderly patients and did not have any underlying disorder causing acquired hemophilia. This is our unpublished data of around 9 patients, including the patient that we have presented today. Also important to note that in this study population, we have patients of varied background and etiologies, including one patient was PLHA and developed acquired hemophilia. One patient was rheumatoid arthritis and developed acquired hemophilia. Also note that majority out of the 9 patients, 7 patients went into complete remission or are doing well with our treatment, except for 2 patients. One patient, this patient who died from sepsis due to immunosuppressive therapy, and the other patient who continues to be on a follow-up, but has a relapsing remitting course of disease and continues to require continued immunosuppression. Now coming to the take-home points, acquired hemophilia should be suspected in a postpartum female or an elderly patient presenting with or without bleeding manifestations with an isolated increase in APTT. 50% patients have an underlying etiology, and it should be tested with the factor assay, mixing study, and inhibitor assay. The management is two-pronged. One is the management of bleed, and other is eradication of inhibitor via immunosuppressive therapy. There are new agents including eculizumab, which can be used for management of these patients. And acquired hemophilia is associated with high mortality rates, primarily due to infections and high chances of relapse. Thank you.
Thank you, everyone. So this is one of the classical cases which we very commonly ask at our DM entrance examinations. We see almost 1-2 cases in a year, not more than that. And it's like Dr. Karthik and Dr. Karma, it's a common question given at during exit examination. So this is one of the spotters which we give many a times. And what more can you ask? So this patient has factor 8 and factor 9 both levels going very low, less than 1%. This was something unusual, and I think first of the patient where we saw this phenomenon. On literature review, we were able to see this thing in very few patients of acquired hemophilia being described with such a phenomenon. So a rare presentation, very rare disease, and something more you need to learn from this again. Uncommon presentation, that's it. So invite questions. Thank you. So acquired hemophilia is usually a disease of elderly, of postpartum common and otherwise commonly seen in patients with autoimmune disorder or in postpartum settings. Nothing much, nothing. So, and elderly it can be associated with at times with autoimmune disorders, at times with malignancies or cardiac defects. So none of them were there in this patient.
We have a hormonal necrosis, considering it's very common postpartum.
No, sir.
Most of the immune disease can happen in postpartum period. Acquired hemophilia is common. Few patients in postpartum acquired usually presents in the gynae prolonged bleeding or subsequent.
even after extensive work, so almost 40-50% of the patient they continue to stay idiopathic. No underlying causes.
What you mentioned according to literature, there are very common drugs we are using like
Yes,
beta
the drugs are common, but in whole the disorder is very rare.
and not if that needs to happen because of drug, then we need to also stop the drug.
Uh, Possibly yes. Possibly yes. If drug is the etiological agent in such cases. The treatment nowadays is easier, but it's very costly, especially for acute bleeds. For acute bleeds, the whatever bypassing agents which we use, they are pretty expensive. The immunosuppressive therapy is more commonly employed for such conditions, even if the patient is having bleed. So the patient tend to respond with the resolution of bleeding within a couple of weeks, but they can have a very relapsing and remitting kind of approach at times. No further queries. Thank you. Over to you.